Good afternoon. My, my name is Melissa Maniego. I am the medical director of the Kidney and Pancreas Transplantation, and we are restarting our Transplant Institute grand rounds today after the COVID era. Purposefully, we have invited Dr. George Alangan, who is the director of the Transplant and Immunocompromised Host Infectious Diseases at Henry Ford, as well as Mayur Ramesh, known by all of you as one of the senior staff in the same division. They will be speaking today about COVID-19, where are we now? Before we start, we have some housekeeping rules. Please stay muted during the presentation. Use the chat feature to submit questions, and there will be a designated Q&A period during the presentation. Enjoy. Thank you.
Good morning, everyone. My name is George Alangan, and it's really a pleasure to be here to talk to all of you. First of all, I'd like to take a moment to thank Dr. Samaniego and Marwan Abdul for inviting Ramesh and me to do this presentation. When we talk about the objectives for this presentation, I'll present an overview of COVID-19 in the general population, and I'll end giving you a brief overview of what it looks like in the transplant population. In the meantime, Dr. Ramesh will then start off with the management soon to follow. So with that said, when I talk about the epidemiology, I'd like to take you through the evolution of this epidemiology, where we started and where are we now. In addition, immunopathogenesis is an area where there's a lot of interest because this dictates the clinical spectrum of disease, the severity of the disease, and the management and outcomes. I'll then move on to the diagnostic approach, and then we'll talk about COVID and transplants. What have we learned so far? When one looks at the timeline of infection so far, it's hard to imagine where we have come. On December 8th, we first learned about the early cases of pneumonia in a seafood market in Wuhan, China. Soon after that, it was determined that this was a novel coronavirus. And then the first cases showed up in Thailand, confirming that human-to-human transmission could occur outside of the China mainland. And then subsequently, we realized that the virus was distinct. It was named as a severe acute respiratory distress syndrome, coronavirus 2, and the disease itself was termed as COVID-19. In March, WHO declared this to be a global pandemic, and then thereafter, there's now 4 million cases and over 270,000 deaths globally. When one looks at the picture of COVID in the United States, you can see here on a map, certain states have more than 40,000, Michigan included, but this represents a total of 1.2 million cases and over 75,000 deaths. In Michigan itself, there are approximately 46,000 confirmed cases and 4,000 deaths. And as you can see here, you can see that most of the cases are clustered at this time in Southeast Michigan, Wayne County, and the city of Detroit. Shown here is the epidemiological curve, and this is encouraging because what we can see here is the number of cases are steadily declining, even though the cumulative number of cases remain high. Furthermore, when one looks at Region 2 South, which includes Wayne County and the city of Detroit, it's really encouraging to see the number of new cases have declined significantly. And this is important for us to know because when we look at the penetrance of this virus in the community, meaning community transmission, a lot of our guidelines about reopening services, screening patients before procedures and surgery, will all be dictated by what this curve looks like in the future. Similar to what we saw in Michigan, you can see within the Henry Ford Health System, a decrease in the number of admitted cases, which is shown in light blue, followed by ICU and then patients on the vent. And if you look at the data from Henry Ford Hospital, you can similarly see the steady decline in inpatients, which is very useful information when we start reopening units for regular care. I've summarized here what the mortality looks like. You can see overall we treated about 3,400 cases within the system. Approximately 25 to 32% required ICU admissions, about 22% mechanical ventilation. Overall, between 83 and 85% were discharged, and we lost about 15% of our cases. Now, as many of you are aware, the average incubation period for this virus is 5 to 6 days, but can last as long as 2 weeks. We also realize the primary mode of transmission is through big respiratory droplets. Some degree of transmission does occur when someone comes into contact with contaminated objects or fomites. Now, aerosol generating procedures such as intubation, extubation, induction of sputum and such, you can see 5 micron size aerosols generated that can linger in the air longer. And that's the reason why these procedures are generally done in a negative pressure room wearing an N95 mask. We also stress the importance of hand washing and hand hygiene because this virus can survive on cardboard for about a day and on plastic and steel surfaces for at least 3 days or so. The virus has also been detected in the stool and whole blood. The significance of this in transmission still remains unknown at this time. Fortunately, 80% of persons with this infection will experience a mild to moderate disease that can be managed at home. About 14% will present to the hospital with severe disease characterized by COVID pneumonia that causes dyspnea and need for supplemental oxygen. And then about 6% will end up in the ICU requiring critical care support for septic shock, multi-organ dysfunction, and respiratory failure. Now, it's clear that there is a group of patients who are asymptomatic, meaning they'll never go on to develop any symptoms. The percentage of this at this time remains unknown. It's believed to be uncommon. But once we do seroprevalence study, we'll get a better understanding of what this number might be. Now, when one looks at the risk for mortality, it's important that the primary risk that predicates severe disease and death is the severity of illness at presentation. Mild disease generally recovers. Patients with moderate disease, most of them will recover without any complications. However, severe and clinically ill patients are the ones who will end up requiring ICU care and where mortality is high. Furthermore, we also realize that older age, the presence of comorbidities, particularly hypertension, diabetes, coronary artery disease, and chronic lung disease, also correlates with severity of disease. And most importantly, one has to realize the geographic location and intensity of transmission that happens also defines would healthcare systems get overwhelmed and where mortality might be impacted. And even these places have shown that later on in the outbreak, when things are brought to bear and resources are available, the outcomes are certainly better. Now, one looks at the clinical features. All of us are familiar with the big three, that is cough, fever, shortness of breath. In addition, there is fatigue, myalgia, arthralgias that can show up and was predominant in China. But more importantly, there are reports from the West Coast that show that 68 to 71% will experience loss of smell and taste. And it's believed that COVID patients are 10 times more likely than other respiratory viral infections to have a loss of smell and taste as they're presenting symptoms. Now, the timeline of symptoms and disease progression is fairly predictable. It's generally around 7 days that patients present for admission. Soon after that, they get dyspnea, go on to get acute respiratory distress syndrome, and by day 10 to 12, they're in the intensive care unit and requiring critical care. And we have seen the same pattern show up at patients who are presented to Henry Ford Hospital. Now, when one looks at the disease, you can look at it as 3 stages. It's believed there's a stage 1 is the early phase of viral infection, followed by the pulmonary stage of COVID pneumonia, and then predominantly the pro-inflammatory host response that causes most of the harm. And based on this, you can also predict what might be the symptoms: fever, fatigue, cough, headache, diarrhea, all predicating the viral response stage, followed then by more progression to shortness of breath, hypoxia, and then features of inflammatory response with ARDS, shock, and SIRS. Ramesh will touch on some of the biomarkers, but just to tell you that lymphopenia occurs early and is a significant pointer to this being COVID infection. This happens with all viral infections. Also later on in the discussion, Ramesh will touch on the potential therapies and how they are targeting either the virus response or the host inflammatory response. Now, when one looks at indications for testing, we have the PCR test, and the main role of PCR test is to screen symptomatic patients so you can diagnose the disease, make your treatment decisions, and then in very select cases, consider using this test to screen patients for high-risk procedures. On the other hand, serology will play a far more important role in telling us the seroprevalence of this disease, namely how many out there got infected and how many may potentially be prevented from getting reinfected. The diagnosis of acute infection is the reverse transcription PCR. This has high analytic sensitivity and specificity. The variable clinical sensitivity that we see depends on the viral dynamics. Is the virus present up in the nose or is it in the lungs? It's a sample of choice. Right now, the nasopharyngeal swab is considered the standard for testing. Alternate specimens, sputum, and tracheal aspirates have been validated at Henry Ford Hospital and specifically have a role when the initial nasopharyngeal swab is negative. Now, when one looks at what are the platforms, there are 5 platforms that are currently being used within the Henry Ford health system, and the limits of detection range from 100 copies to 500 copies of the virus. So these are really very sensitive assays. It's important to also realize the viral shedding is highest 3 days before onset of symptoms and 3 days after, as you can see. And the load of virus found is extremely high, and this might explain the infectiousness of these patients. The duration of viral shedding is believed to last approximately 14 days, but can range as long as 28 days. But you can see from the slide that these numbers, the copy numbers, decline over time. So positive results after 2 weeks indicate some low-grade active infection, or maybe detecting RNA that is non-viable, but still present in the clinical samples. When one looks at testing sputum and tracheal aspirates, you can see the sputum is shown in orange, and you can tell here that sputum samples tend to remain positive for longer than nasopharyngeal swabs. So when do we use the sputum tests? Typically, we use them in patients who have gone to the ICU, where the initial nasopharyngeal swabs are negative, but the COVID suspicion is high. And in these patients, you might be able to get a tracheal aspirate or sputum sample that can be used for testing. The serology is predictable. It's like any other infection. As the symptoms, symptomatic phase starts, you can start seeing the development of IgM antibodies. And then subsequently, as the symptoms fade, you can start seeing the IgG develop. What is not clear at this time is how long these IgG levels will last and what's the impact on long-term immunity. Shown here on the table, which you all can look at your convenience, are the different stages based on what the test results show. But more importantly, what you can also see on the right side is there are at least 70 serological tests that had an emergency use authorization. And most of these tests have resulted in poor reliability with a lot of false positives, false negatives. It's also important to realize there will be a small subset of patients with mild infections or asymptomatic infections that may not seroconvert. And the most important question is how long will it last? And finally, clearly, all the vaccine studies and everything will be predicated on, can you get a good neutralizing antibody response that will cover you against this infection? I just don't want to belabor the point, but like most viral pneumonias, the appearances on chest X-ray, which is unique to COVID though, is that these are bilateral peripheral multifocal infiltrates that are ground glass opacities. They look like a mosaic pattern if you happen to do a CAT scan. CAT scans are not indicated unless there are other complications you suspect, such as a PE or consolidation or some other concerns. At this time, I'm going to then switch over to finish off with an overview of COVID-19 in our transplant population. Just give me 1 second. I'm just going to try if I can get one of these images off my screen. If you hold on for a second. Close. Okay, so just to carry on, what I've shown here is an overview of 9 studies that I could find in the literature that have had more than 4 cases. What you see in column 2 is a study that we have done here showing our preliminary experience. You can see most of the studies are descriptive. The study from Wuhan looked at 10 cases of kidney transplant and compared them to their in-the-house, family contacts who had mild disease. We looked at 47 cases of solid organ transplants. 35 of these patients were hospitalized, and of these 35, they were compared to 100 controls of non-transplant patients who also had confirmed COVID. You can see here across the what you can see in the third row is that most of these are kidney patients. We have some livers thrown in, mostly from the data from New York. New York actually accounts for 140 of all the cases shown here. You can see that most of these patients had a transplant beyond 1 year. So the spectrum of disease in the early transplant period still remains undefined from all of these case studies. Let me just see if I can. Computer has frozen up. Which can this? Yes. Okay. I think we are good to go again. When you look at the type of patients, most of these patients were 60 years of age. They were the majority were male. There was a significant amount of comorbidities, namely hypertension and diabetes. Of note, there are 2 studies, our study and the study from New York, that also examined CKD, and CKD was quite prevalent in this group. The presenting symptoms were predominantly fever, cough, and shortness of breath. However, if you look at it, the majority of our patients also had diarrhea, as was also seen in some of the studies elsewhere. I apologize, the number in our column of current studies is not 26, but 74. So the majority of these reports relate to patients who were hospitalized. The 2 parameters that most of these studies looked at was lymphopenia, which was generally low in most of these patients, and most of them had an abnormal chest X-ray. One looks at the outcomes. The follow-up period ranged from 1 day to 28 days. Our own study was 2 to 4 weeks. If one looks at death, overall, the mortality ranges from 7 in one early study from Colombia, but generally it's in the range of about 20. When we looked at our own data, overall 70% of patients died in this entire cohort, which is compared to 18% from New York. If patients were hospitalized, the mortality goes up to 22%. And if they are intubated, as in New York or in the ICU, the mortality goes up even higher. The other parameters that one can see here is that the ICU stay was quite significantly represented. But most importantly, 75% of patients from our own center were discharged alive, as were some of the other data that shows. One notable feature across many studies is the presence of acute kidney injury. In our own study, using the KidNO definitions, 47% had AKI, 20% went on to develop renal replacement therapy, and many of the other centers report similar findings. Now, some of the reasons behind this we can maybe discuss in our Q&A session, but dehydration from diarrhea, direct viral pathogenesis on the kidney are two of the factors that likely contribute to this. And finally, when we look at our 35 hospitalized transplant patients on 100 controls, you can see that early adjusted mortality was comparable in both the groups. And transplant patients, if they got past the first week, sort of had survived longer than the non-transplants. At this point, I'm going to stop. So what we have seen is evolving epidemiology of SARS-CoV. I've shown you some local data, the spectrum of clinical disease. We talked about the immunopathogenesis, the diagnosis, and finally, I gave you a preliminary overview of the clinical characteristics and outcomes in our transplant population. With this, I'd like to now share the mic with Ramesh.
Thank you, Dr. Alangadan, and thank you to Dr. Marwan Abujud, the Transplant Institute, and Dr. Millie Samaniego for inviting us in this crucial time. My job is to discuss the stratification of disease severity, antiviral therapy, the role of COVID-19 convalescent plasma, and immunomodulatory therapy. So if you look at disease stratification by severity, the biggest data set came from WHO China Joint Commission, their CDC, where they classified mild to moderate as no or mild pneumonia and generally treated outpatient, about 81%. And severe, with anybody admitted to the hospital who have dyspnea or hypoxia, less than 94% and requiring oxygen, and greater than 50% of lung involvement on the imaging within the 24 to 48 hours of admission. And they were critically ill if they were intubated with respiratory failure, shock, or multi-organ failure, which is about 5%. The severe ill were about 14%. The overall case fatality rate was 2.3%, and there were no deaths reported in the non-critical cases. So this is a key slide to understand how we can target managing COVID. So if you look at it, in the early phase, which is the viral phase, which typically happens in the first week to 10 days of onset of symptoms, it makes sense to try some sort of an antiviral strategy. And classically, those people have fever, diarrhea, dry cough, headaches, with or without some lymphopenia, elevated biomarkers. So that's early viral phase. And then a small percentage of patients go into the secondary phase where they actually develop shortness of breath. And that is a marker of excessive host inflammatory response. So it makes sense to do some sort of immune modulation at that point of time, meaning the second week onwards towards till the end of second week or so. There, in addition, you may also get transaminitis, and your serum procalcitonin is usually going to be within normal limits. And if you look at the third phase, is the excessive inflammation that ends up causing ARDS, shock, or cardiac failure with profound elevation of inflammatory markers, including CRP, D-dimers, ferritin, IL-6 levels. Not all of them necessarily have to be elevated, but a majority of them are elevated. So it makes sense to consider potential therapies such as antiviral therapy, which is hydroxychloroquine, remdesivir, or COVID-19 convalescent plasma. It is also possible that COVID-19 convalescent plasma can also act like an immune modulatory agent, and so does a small percentage, like a small effect of hydroxychloroquine is also immune modulation as well, whereas remdesivir is a pure antiviral strategy. So it probably makes sense to use antiviral strategy a little bit early in the game, and which is within the first week to 10 days of the onset of symptoms, and use immune modulation a little bit later in the game, particularly when you start developing exertional shortness of breath. And when it comes to transplants, the data is still a little bit unclear. Do we really need to reduce immune suppression at this point of time? But traditionally, in viral infection, we tend to reduce some degree of immune suppression. But it seems like the immunopathogenesis of this virus is predominantly affecting the innate immune side, activated macrophages, and related cytokines. So, maybe a minimal reduction of immune suppression is all you need, and then target during the immune phase and the hyperinflammation phase of the disease using medications such as corticosteroids, IL-6 inhibitors, IL-1 inhibitors, JAK inhibitors, or IVIG. So if you look at the pathogenesis of the virus, where if it enters into the cell, the first thing that happens is what is called as membrane fusion and endocytosis. The next thing that happens is uncoating of the virus, followed by translation of the RNA material using different enzymes, including RNA-dependent RNA polymerase, and then reformation of the viral particle and exocytosis. So this is what classically happens in this virus. For entry, it needs ACE2 receptor and a co-receptor called as TMPRSS2. And the TMPRSS2 is interesting. Why? Because it is also an androgen hormone dependent molecule. So it seems like maybe males will have more severe disease, or more, and maybe, possibly, we don't know, but that is one explanation where males tend to have much more severe disease that we see. Second, if you look at chloroquine or hydroxychloroquine, that inhibits the viral entry endocytosis level. That's where it acts. If you look at ribavirin, remdesivir, or favipiravir, it acts on the RNA-dependent RNA polymerase, so it works on RNA synthesis. If you look at tocilizumab, it is purely an immunomodulatory agent that binds the IL-6 receptor or inhibits and there are other agents similar, like sarilumab, which inhibits IL-6 related mechanisms. So it's treatment for the hyperinflammation phase. And in the past, early on in the disease, we thought that there'll be data on lopinavir, darunavir. These are anti-HIV protease inhibitors. And I'll show some data to show that it did not pan out like what we thought. So let's start with first, what did we do in Henry Ford Hospital? So if you have a confirmed case or a highly suspected case, we in the ER, we start doing some biomarkers, which is highlighted in the yellow section, where we do X-rays showing bilateral lung infiltrates, lymphocyte count looking for lymphopenia, elevated ferritin, CRP, D-dimer. And then we risk stratify based on this mild, moderate, severe, where mild disease are usually not hypoxic without exertional hypoxia, and the moderate disease have exertional hypoxia and exertional dyspnea, and they require some degree of supplemental O2, and they have pulmonary infiltrates. And we do some daily standard labs inflammatory markers, and we empirically start them on hydroxychloroquine or remdesivir. At this point, remdesivir is still part of a clinical trial program. We just got emergency approval recently. We'll talk about it when we talk about remdesivir. We also do immune modulation in patients who started to require a little bit higher level of oxygen using methylprednisolone, 1 milligram per kilogram for about 3 to 7 days. In severe disease requiring mechanical ventilation, we additionally do some extra biomarkers such as IL-6 levels. And in addition to treatment with hydroxychloroquine or remdesivir, we also do adjunct methylprednisolone for about 3 to 7 days, 1 milligram per kilogram divided into 2 doses. And in select patients who fail methylprednisolone after 48 to 72 hours, we may consider IL-6 depending on a clinical syndrome of hyperinflammation, of which fever and persistent fever is a hallmark. So if you look at in vitro activity of these drugs against, look at C, where this is on Vero cells, Vero cell lines, where you can clearly see both remdesivir and chloroquine seems to act on multiple time points of the viral cells, including like entry or post-entry. So there is profound inhibition. So there is some in vitro data to show that these drugs might actually work. But what about clinical data? So let's start with lopinavir ritonavir. This is an NEJM paper that was published in late March, where it was an open label randomized study to placebo in hospitalized adults with severe COVID and was used as a 14-day PO regimen, one-to-one randomization, 99 people in the drug arm and 100 people in the standard of care arm. The primary outcome was a 2-point improvement in what is called as a 7-point clinical ordinal scale. The scale is nothing but, we will talk about more of these scales. The scale is nothing but if the patient is not hospitalized, they get the lowest points, as opposed to patient dying gets the highest point. Anything in between, such as mechanical ventilation, all those things have points in between. So that's all the ordinal scale is. And it clearly showed there was no improvement in a primary outcome or mortality, and also no improvement compared to the standard of care when it comes to reduction of even the viral load seen in the lower portion of the curves. What about hydroxychloroquine? Hydroxychloroquine mechanism of action, it increases intracellular pH, inhibits viral entry, and pH-dependent viral replication. It also has some immune modulatory effect by decreasing inflammation, reduces IL-6 and TNF-alpha, albeit a very minimal role on immune modulation. And it has 75% oral bioavailability, very high tissue penetration, and unfortunately ends up with a half-life of about 40 to 50 days. Yes, clearly there is concern of QT prolongation and related to SAD. There is cardiac-related side effects. There is also CNS side effects that has been reported, such as depression, psychosis, exacerbation of myasthenia gravis, or dermatology side effects such as rash, hypoglycemia. There has been cases of leukopenia and immune thrombocytopenia reported. Some degree of hepatotoxicity or retinal toxicity can be seen as well, particularly retinal toxicity with long-term use. But overall, the drug actually has a pretty good safety signal despite all these side effects. And in our experience in Henry Ford so far, we've not had any major side effects so far using the drug on its own alone. Maybe with combination of azithromycin, which has been touted, there might be a slightly higher signal for QT prolongation at this point of time. So we wanted people to be careful when they choose to use combination in our hospital, and that seems to be the overall feeling throughout the country as well. So what about the data? There is an expert consensus group that showed chloroquine shortened COVID-19 disease course. And chloroquine is part of their treatment guidelines using their CDC, the National Commission of China. And there are several preprint reports of showing chloroquine's benefit. And there are also several preprint reports showing chloroquine may not have any benefit. So the jury is still out. But the safety signal on chloroquine alone seems to be pretty decent at this point. So nobody really knows, unless there is a randomized study, we would not know that hydroxychloroquine compared to placebo actually shows some improvement of the COVID-19 disease. So this is the latest paper on hydroxychloroquine that was published by the Columbia University people on May 7th, and it's an observational study of hydroxychloroquine in hospitalized patients with COVID-19. They included about 1,376 people where they compared hydroxychloroquine versus placebo with a propensity matching and regression analysis was done. So you can clearly see that when you look for a primary endpoint, it's a composite endpoint of intubation or death. You can clearly see that after propensity score matching, there was no significant difference in the composite endpoint compared to placebo when we use hydroxychloroquine. So once again, this study still did not help us moving forward with hydroxychloroquine or not moving forward with hydroxychloroquine. So there is a PETALS network study called ORCID. That is truly a placebo-controlled study that is multi-center, that is going to be coming out soon, including ND4. And probably that will help us give the answer correctly to this question. What about remdesivir? Remdesivir, the mechanism of action is intracellular conversion to ATP analog, and then it inhibits viral RNA polymerase. And it, unfortunately, only in an IV formulation, and it's formulated with beta-cyclodextrin. In clinical trials, generally you need a creatinine clearance of at least 50, and in the expanded access arm, you need a creatinine clearance of at least 30 and above. It's typically given as a 10-day regimen, 200 milligrams on day 1, followed by 100 milligrams, and very minimal side effects, literally constipation, nausea, some phlebitis, headaches. According to the study protocols, we tend to stop the study drug if the LFTs are greater than 5 times above normal, or there is AKI. But it seems like that safety signal is not there in the studies that have been presented so far. And these LFT abnormalities and acute kidney injury seems to be the direct effect of the disease than the drug. So let's look at what is known on remdesivir so far. So the first study that was published was a compassionate use open label study using any oxygen needs that was admitted to the hospital, and a 10-day treatment arm, and it's a multi-centered international study. They took in 61 patients, analyzed 53 patients, and of which 57% received mechanical ventilation. Outcomes, median follow-up was about 18 days, 68% improvement in oxygen class, and 57% extubated, and 7 died. Unfortunately, there's no comparator arm, and this paper was published in NEJM in April 10. There was no significant adverse signals. So all we know from this information is that it seems like a reasonably safe drug at this point. So what about other studies? So on April 29th, there were many trials that were released all at the same time. The first news that came out was an open label phase 3 called SIMPLE trial, comparing 5 days versus 10 days. There was no placebo arm, and it's on severe patients, and it's a multi-center study. There was no significant improvement whether you did 5 days or 10 days. And with the adverse signal, pretty benign adverse signal, as you can see. So the comment about this study is, all you know is maybe you can get away with just 5 days instead of 10 days. Then there was a randomized double-blinded placebo-controlled study. It's an open randomization, and I'm sorry, it's a double-blinded placebo-controlled study. This was done in multi-center in China, and unfortunately, while they start recruiting, the epidemic in China started getting down, so they were barely able to recruit just over about 50% of the patients. And in 28-day follow-up, there was no significant time to clinical improvement, and there was really no safety signal. And this was published in Lancet. I'll show some extra data being the randomized study. I'll show the extra data in the next slide. Then the most important trial, the adaptive COVID-19 treatment trial, or the ACTT-NIAID trial. It was, the information came out as a press release on April 29th. There were 163 patients, 1,063 patients compared 1-to-1 randomization to placebo, and it's a 10-day IV multi-centered international trial. All they identified was 31% faster time to recovery compared to placebo, with the median duration of 11 days in the treatment arm and 15 days in the placebo arm, which was statistically significant. There was a trend towards benefit, mortality benefit, as you can see, 8% in the treatment arm compared to 11.6%. So based on this interim analysis, the study is still being analyzed and it's not published. FDA actually released the drug using emergency use authorization on May the 1st. So we actually have the drug through that EUA this weekend. It was actually delivered to us through the weekend, and we are defining some parameters as to who this can be approved, can be used for. We still are going to continue conducting our clinical trials on moderate, severely ill, and the expanded access arm as well. So this is the randomized trial that was published in Lancet from China. And as you can see on the left-hand side, there was no difference in time to clinical improvement from remdesivir or control arm. What is interesting on the right-hand side, on the top is where they did upper airway viral load monitoring, quantitative viral load monitoring, and the bottom is the lower airway viral load monitoring. It's interesting that you notice that between the placebo and control, it didn't really show any significant difference whether you checked upper airway or lower airway. And that seems a little bit of a bummer when it comes to remdesivir, but it looks like the NIAID trial actually shows a benefit significantly. So we have to wait for the publication. At this point, we have to trust them. And it seems like if you use the drug a little bit early in the course of the disease, you might actually have some benefit. That's all we know when it comes to remdesivir. What about convalescent plasma? We think convalescent plasma is nothing but once you develop COVID-19, after a few weeks, you recover and we draw your plasma, and that contains viral neutralizing antibodies, and then it infused to somebody who has the disease. That seems to be the mechanism. And we think at this point there may be some truly neutralizing antibodies present. We don't know how much, how effective. All those information is not available. So all we have is a case series that shows different benefits. For example, there's a case series of 5 critically ill patients who received convalescent plasma. 4 out of the 5 effervesced in 3 days, 3 out of the 5 at discharge, and 2 are stable. But the patient displayed same clinical course as patients who did not receive treatment. So we don't know if they got better on their own or convalescent plasma did something. And then there is 4 critically ill COVID-19 patients who received convalescent plasma, including a pregnant person. And the time to transfusion to negative PCR was 3 to 22 days. So once again, we don't know what helped them. Similarly, there's another case series published in PNAS where 10 severe COVID-19 patients received convalescent plasma and tolerated it well. So all we can say is that convalescent plasma seems to be safe in this population, and there may be some benefit. What is Henry Ford's experience? So we participate in 2 different trials. One is called as the Mayo Clinic Expanded Access Convalescent Plasma Trial. And our first patient transfused was on April 17, 2020. And you know, he's our star patient, and his public knowledge, no HIPAA here, Dr. Scott Katz, and he recovered from it. We don't know what helped him because we used a lot of other things on him. And to date, we have had well over 50 patients, including transplant patients, in 5 different hospitals of Henry Ford who have been transfused with convalescent plasma. There is another trial which has just started middle of last week. It's called the Henry Ford Health System Convalescent Plasma Trial, done by Dr. Geneva Tatum and Dr. Lopez, and I helped them. It's an open label 2-to-1 placebo-controlled trial. We have recruited over 6 patients now and transfused 2 today, and we expect to complete the trial by end of this week if the recruitment continues to happen. And this trial will probably help us. It's a pilot study, might help us understand, because there's a placebo arm, whether we are doing something for these patients. What about corticosteroids in COVID-19? Now we are looking at the immune modulatory strategy. So this is something which is, I'll spend a little bit more time. So in the first few weeks of the surge, in the first few days of the surge, starting from say 3/12, 3/16 onwards, there were 15 to 20 codes, code blue arrests every day. Several people were getting into the intensive care unit. And we didn't know how to help these people. There are a lot of people dying or people getting into ICUs. We didn't know what to do at this point of time. So looking at the immunobiology and the immune mechanisms of what is happening in this disease, we realized that maybe there's a small role for corticosteroids because the immune system that seems to be profoundly affected and causing a lot of inflammation. It's the activated macrophages or innate immune system and the cytokines related to that. And classically, we treat them with steroids in other disease processes. But unfortunately, several national and international guidelines, including the CDC, WHO, and eventually the NIH, and eventually IDSA, SCCM, and several other guidelines suggested we cannot use corticosteroids because it may cause prolonged viral shedding or it may cause dangerous problems down the road. And the same way with several Ivy League schools also put in the guidelines to not use corticosteroids. So we went against the grain because we didn't have anything better at that point of time. And we said, why don't we try a short course of corticosteroids? And I talked to the ICU team and they agreed. And we introduced that regimen on 3/20. So the protocol was changed on March the 20th. Literally in 72 hours, there was a dramatic decrease in number of codes and the hospital became from chaos to calmness. So we studied the first 250 patients, of which the people who stayed less than 24 hours in the hospital or did not require supplemental oxygen were excluded, or 4 people died within 24 hours of presentation, so we could not analyze them. Of the 213 patients, 81 were admitted to the prior to the corticosteroid protocol, and 132 were admitted after the corticosteroid protocol. Now, we did what is called as a quasi-experimental design before and after, and when we did analysis on that, there was an odds ratio of 0.45 for a composite endpoint and the individual members of the composite endpoints, including entry to ICU, need for mechanical ventilation, and mortality. So the odds ratio was 0.45, meaning a 55% success in not dying. And when we did a 14-day Kaplan-Meier analysis, you can clearly see how the curve separates out. And we also have data on 30-day now, and the curve continues to separate out. And we have experience in close to 2,000 patients on the early corticosteroid use. So it is 1 milligram per kilogram of methylprednisolone used for 3 to 7 days, like as I said before in the regimen, and early in the game, meaning as soon as they develop exertional hypoxia or exertional dyspnea and they get admitted to the hospital, that's when we use corticosteroids and show significant success. So this is one of the best Henry Ford success stories that helped us change from chaos to calmness, and we naturally passed this on to several other centers because it was unethical to hold this information. It is still under review for publication, and those centers, we used about 15 to 20 of them, when they called us back in a week to 10 days, they said that they had exact same success in terms of how chaotic they were and how calm they become within a week or so. So that is Henry Ford's success story. What about tocilizumab? Tocilizumab is an IL-6 agent, anti-IL-6 agent. So what happens is it's one of the cytokines as the innate immune system gets activated, is one of the cytokines that gets released and that causes a significant inflammation in the lung tissue, for example. And targeting that seems to make sense. And there were several non-peer-reviewed studies that showed that if a patient had persistent fever beyond, because all these Chinese patients did receive steroids, and beyond like persistent fever for 12 hours or more, there may be some benefit along with profound elevation of biomarkers. There were several clinical trials that are ongoing related to tocilizumab and equivalent agents. In one of the agents, the sarilumab trial, they had to stop it for the moderate to severe ill patients. Why? Because they didn't show any significant benefit. More critically ill patients, they are still continuing. So some of the trial results are not back yet. These are randomized controlled studies. But you have to remember, toci is a much more potent agent. A single dose lasts in the body for at least 6 to 8 weeks. It's a monoclonal antibody. So it's like IgG, it lasts for at least 6 weeks, and meaning your immune suppression can linger longer, and you can profoundly get secondary infections when it comes to toci. So we want to be careful about when to use and how to use it. And we are looking at our own toci data that we've used in our hospital after the steroid protocol was finished. We have seen a significant amount of second infection. That data is not out yet. So to conclude, we learned how to stratify disease in COVID-19. We talked about various different antiviral therapies, of which there is EU emergency use authorization for hydroxychloroquine early in the game. And now there is emergency use authorization for remdesivir. And when to use immunomodulatory therapy, and particularly in the success story of Hendiford using early short course methylprednisolone, and maybe there is some role for convalescent plasma, also maybe a little bit early in the game. So that's where we stop. And I just want to point out there are several active COVID studies still ongoing as we decline in the first wave. I hope there is no second wave, including remdesivir clinical trials, immunomodulatory clinical trials run by Dr. Miller, and convalescent plasma trials done by Dr. Tatum, and the ARCHID trial hoping to start very soon and trying to recruit at least some patients from our center with hydroxychloroquine compared to placebo. And there is the prevention trial with hydroxychloroquine called the WIP trial done for healthcare workers, and therapeutic anticoagulation trials called the prephase trial and academic trial to reduce ARDS in the floor and in the ICU as well, done by the ICU team. And there are many more other trials that are also ongoing that are not listed here. So here is where I stop, and I'm going to let Dr. Samaniego take over to ask, to talk about questions.
Thank you very much for your participation. We are going to start discussing several of the questions that were prompted by the audience. Several of the questions we have here. One of the first questions, do you think in Michigan itself, the southeastern cluster may be due to lack of testing in other regions?
Hi, this is George. So one of the questions around prevalence of disease and incidence revolves around how much testing is done. So the question is asking, is that the cluster or the high amount of cases we saw in Southeast Michigan a reflection just of us doing more testing, or they're really an increased risk? We realized that the conditions in the Detroit area in Southeast Michigan is where the initial infection started, and transmission really peaked very significantly very early on. And we realized it's probably not all due to testing, because most of the testing was done in symptomatic cases who showed up at the ED and the hospital. So truly, maybe people congregating together and other socioeconomic factors may have played a role in this. The second question, there were 2 or 3 questions relating to a study that's enrolling. And I just want to say that the data that I shared with you has nothing to do with that study. This was a study that we did just using the first 47 transplant patients and the 100 controls that we did in the infectious disease division primarily. So there are other studies that are actively enrolling patients who are solid organ transplant. There was a question about antibody screening. And the issue is, would it be widely available? At this time, we are waiting on a platform that is FDA approved that can do high throughput testing, so high volume testing. And it's believed that the city of Detroit, Boston, New York, and Chicago are 4 sites for an NIH study where all physicians and first responders will undergo serology testing to get a sense of seroprevalence. There was a question related to AKI pathogenesis, and like I said, from autopsy studies, the ACE2 receptor, which coronavirus binds to, is is prevalent in the GI tract, the lungs, and the kidneys. And the autopsy studies showed coronavirus particles within the tubules and the podocytes, as well as the epithelium. And also when they looked, it was clear that there was an upregulation of the ACE2 receptors in the kidney that happens in response. And similarly, also in the GI tract, there's ACE2 receptors and other serine proteases that are important for binding. And that might also explain why there was more diarrhea outside of other risk factors like medications and so on. The next question had to do with what probes are they used to diagnose. And what I can tell you, the most of the probes, at least for the reverse transcription PCR, are directed towards the RNA polymerase or the structural proteins 1 to 4. I'm not sure what exactly are the proteins used in the histopathology samples for testing, but I don't believe we have done a whole lot of biopsies in these patients yet. There were two questions related to, was the lower prevalence of patients in the cohort less than 1 year out from transplant? And could this have been related to a blunted immunological response? And that certainly is a possibility. When we looked at our own small study, where we also factored in transplant patients had far more comorbidities, but they had the same mortality outcomes as non-transplant. So we're analyzing the data in some detail to see if the immunosuppression that they're on could have blunted the immunological response. And one of the people asking the question have said that in IBD patients also on biologics, they're seeing the same pattern. There was one question related to, would there be widespread testing for asymptomatic carriers and what is the carriage rate? At this time, we have data from nursing homes and cruise ships. So in the cruise ships, if you remember, there was a couple of cruise ships anchored off the shores of different countries. And they followed these patients and they did repeated testing, and the asymptomatic carriage among the passengers where they never developed symptoms but tested positive was 18%. Data from the Seattle nursing homes, 20 of 48 residents tested who were asymptomatic tested positive, which is almost 50%. But these are all congregate settings in close proximity and may not be reflective of the data widespread in the population. Finally, the last question that I'll address, which was directed to me, had to do with Kawasaki disease, like disease being seen in children who tested positive for COVID. As many of you are familiar, the last report of 15 cases came from New York of 1 death. The patients ranged in ages from 2 to 15 years. 4 of this 15 patients tested positive on PCR. 6 of them were PCR negative but tested positive on antibody. What we do know is the pattern looks similar. Kawasaki, typically there are 3,000 cases every year in the US, mostly less than 5 years of age. So as we follow these patients along, if you start seeing more cases reported this year and more outside of those age groups, then there might be something to be directed. I'll give that mic over to Ramesh to address some of the other questions.
Thank you, sir. So some of the questions that was directed to me is, first one is, have other clinical studies shown similar results in survival probability with steroids? Unfortunately, ours is the only trial that is at least out on a public server called medRxiv. And there is clinical experience by several centers in Michigan and a few other centers in the country. In China, when they use data, and there is at least a JAMA paper that shows in severe disease that there may be some potential benefit when you use steroids, but nobody did what we did so far to say this. So based on this information, our paper was actually discussed on the Senate floor last week, trying to tell people about how like we may not be managing these disease more appropriately, and so they were trying to plead with the Senate to try to see if we can change something. But more to come down the road as we are collecting more data. Next question is, what about the role of ACE inhibitors are susceptibility to COVID? There are ongoing clinical trials for use of losartan. And not all ARB are created equal. So there's an ongoing losartan for either both prevention and also as an adjunct to treatment compared to standard of care that is actually going to be started in Henry Ford as well. I believe it's already started, if it is not started yet. That was done through emergency room physicians. And when you look at the ARB data, initially there was a concern that there may be an ACE and ARB data, ACE inhibitor, that there may be an increased ACE2 production, and that might promote more worsening disease. But when they looked at what is known, and then several major societies, including cardiology and other societies, have come back with information saying that if you are stable on an ARB, there's no need to drop that ARB. But in the ICU, if you have other reasons to drop the ARB, maybe you should drop the ARB. Okay, so that is where the data is at this point of time. Next question, important question is, what about routine anticoagulation for moderate to severe COVID in hospitalized patients? In Henry Ford, after much deliberation, they came up, the anticoagulation subcommittee came up with a therapeutic anticoagulation guideline. So I would encourage all of you to look that up. The gist of it is if everybody who comes admitted to the hospital will be on prophylactic heparin at 0.5 milligram per kilogram of Lovenox or equivalent, adjusted for creatinine clearance. That's the minimum. But if they have additional risk factors such as obesity, greater than BMI greater than 35, or if they fall under a higher risk using something like a scoring system, like a PREDI scoring system, or particularly they're getting worse in the ICU beyond a certain amount of days in the hospital. So based on these people, they have ideally encouraged people to go into the clinical trial portion, which is being conducted by ICU. But if those trials are not available in satellite centers, for example, maybe you can consider slightly higher dose. These are people who have not been diagnosed with DVT or PE. They have been advised you can give a slightly higher dose, Lovenox, it's 0.5 milligram per kilogram, Q12, adjusted for creatinine clearance. So it's almost like a trauma dose. So it's called low-level therapeutic anticoagulation. And obviously, you would have come across trials from Mount Sinai that also talked about therapeutic anticoagulation based on various parameters and stuff like that. Once again, we know it's a very highly prothrombotic state. We know we need to do some sort of anticoagulation, but we don't want to overdo on everybody because there's a higher risk of bleeding. Because we ourselves have seen several bleeds, including GI bleeds, CNS bleeds. So it's a balance of how do we do it. So we need to have some sort of a balance in terms of how we do therapeutic anticoagulation. Next question is, when the PCR is positive on therapy, is it persistent or non-viable particles? Nobody knows. Nobody knows at this point. The longer you go, the less likely it is going to be viable. When we look at the back-end way of quantitating viral load particles in Henry Ford, we find clearly what is called as the cycle threshold, meaning in a PCR, the lower the cycle threshold, the higher the amount of virus that is present, compared to a cycle threshold, which is very high. So the longer you go away from the disease, the cycle threshold value starts going higher and higher. So meaning they are likely dead viral particles, dead viral RNA. But unfortunately, we are not sure, unless we are able to culture them, we are not sure that they are truly dead or not, and we don't have the capability at this point of time. What about TOC? Have you seen hepatotoxicity or thrombocytopenia? It's very hard to say. That because most of the people, when they use TOC in our center, were severely ill people. So it could be a direct effect of the disease itself. So we don't know. And the last question is, does BCG cause predictive effect? You know, I wish that is true. There seems like immunologically, there seems some role for it, because BCG it's actually increases TLR7 or actually calms certain level of immune system by going through TLR7 and actually increasing a specific type of T regulatory cells. That's what BCG does. But does it mean you got to get BCG every month and to achieve this? Nobody knows. So it was just a theory that seems to be very interesting. So we don't know. Is that the reason why there is less deaths or infections at this point in India? We don't know. Maybe we are not testing enough in India. Maybe the people are doing better social distancing because it's one of the 1.3 billion people are asked to do social distancing and they actually achieved it. So we have no idea whether this is true or not, but it's very interesting. That's all I can say. So, but thank you very much. And I'm going to, Dr. Samaniego is going to give the final words on it. And thank you very much for attending.
Thank you, Dr. Alangandan and Dr. Ramesh. We appreciate this fantastic lecture and the active participation of the audience. We appreciate your attention and contributions. Thank you very much for attending. Thanks.